Thank you for joining us today to learn more about the Center for Population Health's Community Health Needs Assessment and Health Indicators. My name is Katie Basilevich, and I am the Cottage Health Vice President for Population Health and Marketing. Cottage Health conducts a triannual needs assessment to understand the health and well-being of Santa Barbara County. For this most recent needs assessment, we concluded data collection and released a county-level report in late 2019. We last collected these data in 2016. We designed the 2016 Community Health Needs Assessment to establish a baseline and serve as a comparison for future years. Since then, Cottage Health has made these data freely available and easily accessible to the public to drive decision-making among community organizations. We've also developed Population Health's programs and initiatives to address vulnerable populations and health inequities identified through these data. We know that addressing the health inequities and needs identified in this assessment will take time and a community-wide response through intentional partnerships and a focus on those who have been disproportionately affected. The goal of today's webinar is to share newly released data from our 2019 Community Health Needs Assessment, show where the information can be accessed on our Center for Population Health website, and answer any questions you may have. Our long-term goals are to continue to engage in community conversations with organizations representing populations most in need. We plan to further analyze and expand the health profiles, continue to present the CHNA and Data2Go to community organizations, and respond to data inquiries and requests. We are in the process of hiring an epidemiologist with a goal of partnering with community organizations to dig deeper into the data and collaborate on programs and initiatives to continue to help improve the health of our communities. I want to thank our partners who provided guidance and help with the design of the survey and overall approach, including Lompoc Valley Medical Center, Planned Parenthood, the Santa Barbara County Health Department, the Santa Barbara Foundation, the Santa Barbara Neighborhood Clinics, UCSB, and the University of Pittsburgh. Now I'd like to introduce Monica Ray, our Population Health Strategic Development Manager.
Great, thank you so much, Katie. Today, we're excited to share with you the newly released data and findings from the 2019 Community Health Needs Assessment, or CHNA. The data we are sharing is really meant to provide a look into some of the findings and a brief overview of how to access and dive into these data yourself. I'd first like to thank our partners at the University of Pittsburgh who helped with the development of this survey, collected data, and brought expert statistical analysis to these findings. On the line today from the University of Pittsburgh, we have Todd Baer, co-director of the Evaluation Institute of Public Health, director of the Office of Health Survey Research, and assistant professor of behavioral health sciences. We also have Nora Bridges, medical anthropologist at University of Pittsburgh Public Health. And I'd also like to thank our partners at Measure of America, who helped create Cottage Data2Go and have updated it with new CHNA data. We have joining us today Rebecca Gluskin, Chief Statistician and Deputy Director. We'll have a time for Q&A at the end. Please feel free to type your questions in the chat. I'll stop periodically throughout the webinar and we'll ask you to respond in the chat to a few questions and prompts. The goals of this needs assessment were to gather data to better understand the current health and well-being of Santa Barbara County residents. These data were really meant to bring light to health inequities, and in 2019 brought an added focus to behavioral health, which is defined as the broad range of mental health and substance use needs. The CHNA is intended to provide really an impartial and independent source of reliable and fully sourced data that's available to decision makers and to guide program development and strategies for those working to improve the health of the community. In 2019, as Katie mentioned, we had the privilege of bringing together a group of partners, all of those who you see listed here, who provided guidance and helped with the design of the survey and overall approach. Again, a huge thanks to this group for their contributions to the Community Health Needs Assessment. In 2016, as an overview and some background on the Community Health Needs Assessment, we developed a model for the Community Health Needs Assessment that established a baseline in 2016 that we could really replicate in future years. The 2019 CHNA followed that model, and there are two main components of the needs assessment. First, a randomized telephone survey. This was conducted using the same methods as those used by the Centers for Disease Control and Prevention's Behavioral Risk Factor Surveillance System, or BRFIS, which is the nation's leading system of health-related telephone surveys that collect data about health and health-related risk behaviors, chronic health conditions, and use of preventative services. BRFIS now collects data in all 50 states, and using these methods allows us to have a robust set of county-level data to compare to state and national benchmarks. The 2019 CHNA collected nearly 900 random responses from adults age 18 plus. We know from state and national trends and our own experience that it's hard to get people to answer the phone for a telephone survey. In particular, some populations can be even harder to reach. So to help address this, we structured the second component of the community health needs assessment, the listening tours, to include community members representing those more vulnerable populations. The listening tour included 30 focus groups and interviews in English and Spanish with more than 250 community members. Based on guidance from community partners, we focused the listening tour specifically on behavioral health. After we collected the data, the randomized telephone survey data were then weighted to make them representative of the demographics of the county. So what did we learn? We know that this is the question on everyone's mind. And as we go through these takeaways on the next slide, I'd really love to encourage you to add to the chat your reaction to a takeaway that stands out to you. So a couple are on this slide, and as well as a few more on the next slide. The first thing that stood out to us is that the randomized telephone survey showed that overall Santa Barbara County continues to do well. In the 2019 Community Health Needs Assessment Report, which is available on our website, Appendix A shares 135 indicators representing questions that were asked on the survey. Of those, as a county, we fared worse than the state for only 39 of those. This story does not hold up, though, at the subpopulation level. When we look at the data broken down by demographics such as race, ethnicity, income, and education, we see that disparities exist among these subpopulations. And this is similar to what we saw and shared in 2016. And then based on the data, we identified priority areas for the Cottage Center for Population Health. These next few takeaways on this slide and the next are from that prioritization process. And this includes that behavioral health remains a top need and opportunity for improvement in Santa Barbara County. Access to care has decreased and continues to affect marginalized populations disproportionately. And then chronic conditions remain a top health need. Resilience. Communities experiencing systemic racism have shown incredible resilience, which can be supported by clinical programs like ACEs screening and referrals. And we also heard that social needs such as food insecurity and housing insecurity have improved for some populations in need and have gotten worse for others. We also heard from listening to our participants that fear continues to be experienced by Hispanic Latinx community members. And there's a lack of cultural competency that continues to be a challenge in healthcare and in mental health services. So for the listening tour, we invited participants to share their input on root causes of behavioral health challenges, as well as the barriers and facilitators to accessing behavioral health services. We designed these focus groups and interviews to really engage and amplify the voices of those who are the medically underserved, those who are low-income residents, people experiencing homelessness, youth, members of the Latinx and LGBTQ plus communities, and then together with the randomized telephone survey data, these data really gave us a fuller picture of the needs affecting the county as a whole and the subpopulations. After collecting these randomized survey data and conducting the listening to our focus groups and interviews, we really set out to use these data to guide Cottage Center for Population Health's priority areas for the next 3 years. The process we use here is an example of how a community organization or those doing population health work could use these data to drive decision making. To do this, we set out by building a process that would prioritize health indicators, and it was a process that we had established in 2016. And in 2016, Cottage Health had selected 13 leading health indicators that would serve as the focus for analysis. These indicators were selected based on assessing emerging local health trends in the 2016 CHNA, as well as reviewing state level data from the state BRFIS and leading health indicators from CDC's Healthy People 2020 targets. Based on results from 2016 and conversations with community partners for the 2019 Community Health Needs Assessment, we added behavioral health indicators for 2019, and that brought us to a total of 18 leading health indicators that we looked at for deeper analysis. To prioritize these health indicators, we created a score sheet. We rated each indicator against the Healthy People 2020 target, which is a national objective that's set by the federal government and designed to identify the most significant preventable threats to health and establish national goals to reduce those threats. As I mentioned, we also looked at the California BRFIS data, and then we looked at the extent to which certain populations that are broken down by race, ethnicity, income, and education are disproportionately affected by the indicators. And then the fourth area that we considered and brought into this prioritization process was the extent to which the indicator was mentioned as a need by internal and community stakeholders through a listening tour follow-up prioritization survey. So we went back out to those individuals who had participated, especially the community leaders who had participated in the listening tour, and we asked them to help prioritize based on need and urgency, existing resources, some of these health indicators. What emerged from this prioritization process are these 5 priority areas. These differ from our 2016 findings slightly in that resiliency emerged as an area for attention and has developed community momentum over the past few years. In addition, food and housing insecurity are areas that were grouped together and are encompassed more broadly by social needs or basic needs. And then within each of these 5 priority areas, as you can see on this slide, these are the health and well-being indicators that are represented. So I mentioned the health indicators that were selected. This defines what falls into each of those categories. And we used each one of these health indicators to create a health indicator profile around the data that were found here and did cross-analysis with demographics and other health indicators. So in the next few slides, I'll dive in and pull out a few examples of these health indicators, and we'll walk through examples of how we analyze the data. The purpose of this is really to give you a glimpse into some of the analysis that occurred around these health data and to show you what exists online on our website in the health indicator profiles. So this is a glimpse. I'll also move over to our website to show you exactly where this is located after we walk through this. So one indicator that we wanted to share pertains to adults who identify as having access to a primary care provider. Having a usual source of healthcare improves health outcomes, and we know that it reduces disparities between groups and can lower healthcare costs. In addition, we know that regular checkups and screenings can help diagnose and attend to diseases at earlier, more treatable stages. So as you can see in 2019, there's a slight decrease from the 2016% of adults with a primary care provider, and we're overall lower than the state and below the Healthy People 2020 target. So similar what we saw in 2016, when we break down this data by subpopulation, the needs are really even greater. In this case, it's better to have a higher number of adults that are connected to a primary care provider. And so in this case where red items represent those that are 15 percentage points lower or worse than 15 percentage points or more lower or worse than the 2019 county rate. And then the orange represents less than a 15 percentage point difference for the worse than the 2019 county rate. And as you can see here, those who have a high school degree have lower rates of accessing primary care providers, those who are age 18 to 44, who are Hispanic, Latinx, and those in the lowest income bracket identify as having less access to a primary care provider. We also heard from the listening tour that some information that really helped us to better understand and contextualize what is happening around this particular indicator and this area of need. Among community members that participated in the listening tour, we heard that language and cultural barriers were an issue when approaching mental health care services. And in some cases, children are having to translate for their parents in clinical settings due to a lack of bilingual providers, which adds to a potential barrier to accessing primary care services. We heard that Hispanic Latinx communities, that even when a healthcare professional is able to speak Spanish, they may not understand their particular cultural background, and that is an added barrier. And it makes it difficult to provide effective and appropriate care. And in particular, we heard that there's a lack of providers who are able to speak Mixteco. One Hispanic Latinx youth community member said, "I don't see a lot of bilingual doctors. They don't really speak Spanish. So usually if I go to the doctor, I have to translate to my mom what the doctor is saying." And then a mental health provider shared, "We as professionals are not representative enough of the people we serve." The next area in health indicator profiles that is actually new and really different from what we shared in 2016 is this correlation, or these correlation graphs that exist across the health indicator profiles and are within the downloadable PDF version that I'll show you on the website. These show a relationship that between each of the health indicators, between what that health indicator has with other health indicators. We conducted a correlation analysis to identify which of the 22 health indicators are most associated with having a primary care provider. And in this example, we see of the adults who reported having diabetes, 88% have access to a primary care provider. Of the adults who reported no insurance coverage, only 24% have access to a primary care provider. And of the adults who reported Medicaid or another state-provided insurance, 63% have access to a primary care provider. Another indicator that we wanted to share reflects food insecurity in Santa Barbara County. The lack of access to adequate food affects both physical and mental health. And you can see that in 2019, the county rate is the same as the rate in 2016 and similar to, and then for the Healthy People 2020 target, it is worse than the Healthy People 2020 target. There's no statewide comparison for this particular indicator, and that happens upon occasion based on the question. When we break this down by subpopulation, we again see here that the need is even greater, that those amongst the lowest income group and those without a high school degree experience disproportionately higher rates of food insecurity. Those who are Hispanic and Latinx and those who are age 18 to 44 also have higher rates. And we know that of the data collected of this needs, we know that of these data, that there's much more to understand here. We know that this is a glimpse into time in part, and we know that this occurred pre-pandemic, and as these data were all collected in 2019. So to talk about that for just a minute, what we can tell here is that this can show a baseline for where we started before the pandemic, where the needs existed, and what we are hearing and seeing firsthand now is helping us to better understand how these needs have shifted over time. What we're hearing from community organizations that are really living and happy and experiencing these needs and seeing them right now is that these needs have increased, and we've seen that demonstrated in a couple of articles that have appeared in the News Hawk and in the Independent. I know that for those who are service providers, we hear this all the time. Food insecurity has increased. So as part of next steps for the we plan to conduct a community conversation with organizations who are serving those most in need. And so through these conversations, we will gather a snapshot of what's happening during the pandemic to add to these health indicator profiles on our website. So more to come here, and there's more of a story. As with many of the indicators that we're looking at today, we know that changes have occurred and changes will continue to occur. And as we continue to understand those needs, it will be important to capture that and continue to communicate that back out and share those with the community. As I've mentioned before, we conducted the 2016 needs assessment with the intention of establishing a baseline. And in the health indicator profiles this time, we've pulled out several demographic subgroups that are most impacted by needs and compared them to the 2016 rates. Here we're sharing a comparison for food insecure adults by highest level of education attained. And I'd love to pause, and I know nobody's added any questions to the chat yet so far, but if you have any thoughts, we are actively looking for community members, input and community organizations to share any thoughts on why you may think that this particular indicator around individuals who have less than high school education has decreased in 2016 from about 48% to about 41% in 2019. What that tells us is that individuals who have less than high school education, who are disproportionately affected by food insecurity, are experiencing food insecurity potentially at a little bit lower rate, and that's what the data is showing. What we want to understand is how has that happened? What programs and services have really led to some of the improvement that we're seeing there? And in this case, the disparity that exists between those who are in college and have some college education, those who are college graduates and who have some college graduates, they also increase in their food needs. So it's going a little bit in the opposite direction, but what is an outcome of that is that there's a little bit less of a disparity. And that is exactly, I see in the chat, somebody added, what do we think is driving the lower rate of food insecurity in the group with less than high school education? That's exactly what we are seeking to understand as well, and will be a next question. Any community organizations or participants on this call are welcome to add to that, and if you have any thoughts on that, we're interested in hearing them in the chat, but we'll also be participating in community conversations as a next step, reaching out to organizations such as for this indicator, like the Food Bank and Communify, to better understand the efforts that are going on and see if it makes sense for what they're seeing amongst the populations that they're serving, that this type of disparity would be improving as well. In another comparison to 2016, we see that food insecurity has increased amongst those people who are Hispanic Latinx, and that the disparity has also increased between the Hispanic Latinx population and those who are non-Hispanic, white, and other. And so you see from 2016, the numbers increasing for the percentage from about 31% to about 33% in 2019, and then moving for those who are non-Hispanic white, who identified as non-Hispanic white, moving from about 16% to about 15%. So a very small decrease, and so the disparity there increases, and as well as the percentage of those who are identifying as food insecure. And just taking a look at the question, is it 40.7% of people who need to have food, have less than a high school education, or is it 40.7% of people with less than a high school education are food insecure? So it is the latter. So 40.7% of people with less than a high school education are food insecure. Great, thanks, Maddie. Okay. All right. I'm going to just keep going here. These are really great questions that are coming into the chat. Oh, I see one from Adriana Mariquin. CalFresh outreach for college students has increased significantly. Could this be why we see the increase in college educated? That would be a great hypothesis. So thank you for adding that information. Also, for less than high school education, perhaps they now have children that can support them. It's a great hypothesis and question there. And therefore remove the food insecurity that was real to them while their children were young? Is there a data point for adults with children? That's a great point. And you ask a good question there regarding children and breaking these data down in different ways. So what we've pulled out in these health indicator profiles is a glimpse into the data analysis, into the questions that can be asked of the data and what it can tell us. We did not ask questions of children as part of this survey. We did potentially ask if adults have a child living in their household. So it would be another way to analyze the data, and we'd have to take a look at the questions that were asked to see if we could answer that question from this information. And then where we know this data can't answer all of those questions, we would pull in secondary data sources. For this one, we may be able to better understand from sources like kidsdata.org or the California Health Interview Survey.
Hey, Monica, there's another hypothesis from Katina. She shared that probably the huge push in the last few years of breakfast and lunch on high school campuses may have impacted what we're seeing there as well.
Great, thanks, Amma. That's another good one. And that kind of information and happenings out in the community help to contextualize this even more so, and help us to understand, especially during COVID times like this, of what's happening in the community and how changes in the services being offered could have an additional impact. And then I see a question from Kristen Sullivan. Are these figures statistically significant, or are we really looking at no significant changes from 2016 to 2019? That's a great question. So these data are representing a mix of statistical significance. And in the health indicator profiles, we have indicated through kind of a caret top or an asterisk that marks where there are statistical significant changes between the 2019 and 2016 rates and I think we used the national benchmark for comparison in that case. We also included the confidence intervals. And in the method section, I think we explain how to use those confidence intervals to tell if these are statistically significant. It was our desire to make these data transparent and widely available for use, yet we also want to make them understandable. So we put all the information out there, and if you have any questions or you have any as you dive into the data, you have specific questions like this, or if anybody who's not as familiar with data needs help to look through the methods or understand it, you're welcome at any time to reach out to us. We're available to help you sort through that and to answer those questions. And then what is the margin of error for these numbers? Since it is less than a 10% increase, is it really, really better? So yeah, so I think this is a great question, and I think Todd is on the line. Perhaps you can jump in here as well. We'll help us conduct some of this analysis.
Sure. Yes, that is a great question. The 2019 data overall has a margin of error of around, I think it's 4.5%. So anything within that range is likely not going to be significant. What we see here oftentimes are differences within a year. So obviously, looking at the graph here, we can see differences between the non-Hispanic whites and the Hispanic populations, and those are significant differences. But the differences between 2016 and 2019 being only a 1 percentage point would be well within that margin of error, and are likely not statistically significant. As Monica said, we outline this clearly in our documentation online. But this is to just show that, hey, there is a disparity here, and it seems to be trending away from where we want it to. And that's the kind of information that's here. But good question. Thank you.
All right. Thank you, everybody, for those questions. Please feel free to keep them coming, and I'll try to pause throughout. The other indicator that we wanted to show you, and this is the last one before we jump over to the website to show you how that works, and then leave some time for overall question and answer at the end. this indicator pertains to depression, and it pertains specifically to adults that have indicated that they have ever been diagnosed with a major depressive disorder. We know that mental health and physical health are closely connected, and each one affects the other. Mentally healthy people can more easily maintain good physical health, and depression can reduce people's ability to take care of their own health. We can see here in that 2019, we are seeing a higher rate of diagnosed depression from 2016. We're also seeing higher than the state and below the health and higher than the healthy people, not reaching the healthy people 2020 target. And then I'll note that with this indicator, we would expect to see an increase over time, because as time increases, more people would likely be diagnosed with would likely be diagnosed with depression. So, for example, many of the same people who were diagnosed with depression in 2016 are still living, and therefore still have a history of being diagnosed with depression in 2019. And something to think about, though, is that we have about a 6 percentage point, we're seeing a 6 percentage point increase from 2016 to 2019. And that feels notable, and as Todd said, trending in a direction of increasing. A good comparison for this is that in California's 2014 birthday survey, the state reported that 13% of adults that were ever diagnosed with depression, versus in 2018 in the state California birthday survey, 15% of adults. So that's an increase from 13 to 15% from 2014 to 2018, and we're seeing an increase from 18% to 24%. So again, broken down, we wanted to share you with this, the percentage of adults that are reporting depression by race, ethnicity in 2016 and then in 2019. And we wanted to understand this indicator in particular, because when we saw this in 2016, it just didn't quite make sense to us. We asked a lot of questions. We had some conversations out in the community with organizations to understand why this may be happening, and we had a hypothesis coming into this 2019 Community Health Needs Assessment. The data show that those who are non-Hispanic white individuals report depression at higher rates. And even with the increase that we see in 2019 amongst Hispanic Latinx diagnosed depression rates since 2016, it's still even higher amongst those who are non-Hispanic white. We intentionally structured the behavioral health listening tour as a key method to better understand indicators like this and the indicators within the space of mental health, particularly amongst the Hispanic Latinx community members. And through the listening tour, members of the Latinx community in Santa Barbara County said that they are experiencing higher rates of anxiety and depression. And yet Latinx community members shared that they are not seeking care due to a prevailing fear in a racist social climate and the cultural and language barriers they encounter during clinical encounters. So this particular indicator is a national indicator that's used for tracking depression or assessing rates of diagnosed depression. And what we've always been perplexed by is the rate of Hispanic Latinx diagnosed depression truly lower than it is amongst those are non-Hispanic white individuals. And we hypothesized that potentially there were some other barriers coming into play, and the 2019 listening tour really helped to draw out a better understanding of this, and that individuals who are Hispanic Latinx are experiencing a lot of fear, as we mentioned before, due to a racist social climate, and that when they go to the doctor, they feel like there are language barriers and there are cultural barriers that impact their ability to seek care. And thereby, we could hypothesize may be impacting some of these diagnosed rates of depression. So another feature of the health indicator profiles that we wanted to share with you and just point out here is that there's really a rich qualitative data and qualitative data and findings that are shared in the listening tour sections of the health indicator profiles. We incorporated them into every health indicator profile that we could pull from a behavioral health listening tour. So that didn't match up with every single health indicator where we did a health indicator profile, but where the findings were able to be brought in, we added that into it so that you can see that firsthand and see analysis plus quotations from participants in the listening tour. And these conclusions and themes can be seen here. So at the end of each of those, that analysis, we share a couple of recommendations. And for depression, these themes emerged as recommendations for how the community can build a stronger behavioral healthcare system to help address depression and anxiety. Amongst those were dismantling stigma, providing more support for primary care physicians, especially around providing culturally competent care and providing translation services, and then leveraging social media as a tool for good, and providing workshops that raise awareness and provide tools and resources, especially to service providers. There's a question in the chat I see of, do you know how often primary care physicians are asking employees to complete a self-assessment for depression? That's a great question. We did not ask that. And particularly amongst the primary care provider employees, we have not asked that either. So that would be something to look into. So as I mentioned, we're with the community conversations, and we want to partner with community organizations to better understand how they're seeing these rates amongst them, if these data make sense, and if they have other information that they're interested in understanding or can help contextualize. And if you have any suggestions, please feel free to add them to the chat box here. If you have any suggestions of who we should be talking with to help understand any of these indicators, and you're also welcome to reach out to me or Population Health afterwards to share suggestions of who we should talk to and other data sources or other indicators in the community that could help us to better understand what we're seeing and the rates of mental health needs or rates of health outcomes across the county. Then I'm going to take these other questions. During the listening tour, were native Spanish speakers used to collect the reported information of native indigenous speakers, or was a translating service utilized? How do you account for community members that do not have working phone numbers? How were the participants selected? What was the rate of no answer or decline to participate? So there are kind of two pieces a part of that question. One is about the listening tour, and we did conduct the focus groups in Spanish and in English. And we also, we had desire to collect data from the Mixteco community, but we had representatives that spoke Spanish from the Mixteco community or worked with those individuals, so represented them as part of the listening tour. We weren't able to conduct a focus group in Mixteco, working with the indigenous speakers there. We are definitely interested in continuing to collect and understand the needs around that specific population, as well as other subpopulations in the county. And then the second part of this question, I think, is around individuals who don't have working phone numbers and how participants were selected, and then the rate of no answer or decline to participate. Yeah, I'd have to look back I don't have the rate of no answer or decline to participate. I'm happy to follow up offline with that one. It was high, the rate of no answer. We, as I mentioned earlier, it was a challenge to gather, to get people to answer the phone. And we used every day, extended out the period that we could to collect as much telephone survey responses as we possibly could. All of the data that we collected through the telephone survey that are reflected here are from a randomized sample. So we worked with telephone companies, and this is where University of Pittsburgh was able to bring in their expertise, where they collect this type of data for other states, including states on the western side. And we were able to randomly dial landline and cell phone numbers to select participants and ask them to participate in this health survey. The full methods for that are seen in the 2019 Community Health Needs Assessment Report, which is available on our website. Another comment is, it will be very interesting through time to see how significant and negative impact of the pandemic on many of these indicators is in 2020 and beyond. Yes, we completely agree. And We have been collecting these data every 3 years, and we know that in the next round, some of this pandemic impacts will be reflected, as well as in community conversations and the other qualitative data that we're able to add to this conversation will help us to better understand those needs that are resulting because of the pandemic. So the question, is there any plan to begin collecting information about LGBTQ disparities? Yeah, so this, again, through a telephone survey, was a harder population to reach. We did include specifically representatives of this population as part of the listening tour, and you'll see throughout the findings that this particular subgroup is represented amongst the listening tour findings and spoken to there. Are there programs within our schools to reach our youth regarding mental health? Yes. I love that question, and part of that is because we know that there are great programs that exist within our schools, led by the school district, mental wellness center, amongst others, and we are also supporting through our new behavioral health initiative grants program, focused specifically on youth. We heard loud and clear from this listening tour that there is a need amongst the youth and young adult population for behavioral health needs. And so that was an area that we focused the grant on, and we are well aware of and will be funding some of those efforts. Given the barriers described for Latinx community members, it seems that community outreach efforts such as those led by promotoras would be an effective strategy, including those who speak Indigenous languages. What other ideas have you considered to address these barriers? That's great. So these data are being collected for the use of both Cottage Health as well as for community organizations and agencies across the county. So we use these data, as I mentioned before, to help set our focus or priority areas. And from that, on our website, we have our implementation strategy that's posted, and that shows the programs and initiatives that we have to address these needs across various populations, and including amongst the Hispanic Latinx population. We know that it will take a community-wide effort to really move the needle, and it will take time to move the needle on these indicators, both at the county level and at subpopulation levels. And so we'll look to you and be interested in hearing also from community organizations what solutions you may see as well to address some of these needs. And then, have you accessed the data available on the Santa Barbara County Community Data Dashboard recently launched? There's a lot of great data there. Yes, we love this site. We help to provide input on the creation of it and think it is a tremendous resource and providing updates for the community. There's a community section of that I think provides some really valuable real-time data of what's happening, or more recent data, especially in the past few months due to COVID. And as we move forward, we'll be working with that team to see if there are other areas that we can help provide support to build out that community section and link to either some of these data or other real-time data sources that are able to provide context for what's happening during the pandemic. Great. I'm going to keep going. And actually, at this point, I'm going to switch over so that let me see if I can do the switch really quick. I'm going to switch over to the Cottage Health website so that you can see where these indicators, where these health indicator profiles are located on our website. So, all right. So on the Cottage Health website, when you actually, if you go to cottagehealth.org, and if you just type in the shorthand version of /PopHealth, cottagehealth.org/PopHealth, you can see on our website that we've actually updated our main page, and excited to be sharing this with the community. Under the Community Health Needs Assessment, there's particularly a section around the Community Health Needs Assessment that has been all updated with 2019 data. And within here, there's a lot of good information that I encourage you to check out, and I'm going to point to the Health Indicators tab. And there's a section within there, you'll see the 12 health indicator profiles that I mentioned. And you can click on each one of those. I'll start with just food insecurity and show that within food insecurity, we have a shortened version that's available on the webpage itself. And then we have a full profile available here, as well as a background and a method section that's available in each of these. It links to the same method section, but it provides a little bit more of that description of how we created these, how we did this data analysis of what you're seeing in the health indicator profile. So when you click on the health indicator profile, it takes you to this PDF. And within this PDF, you can see that there are some of the sections that I pointed out. This one, I think, is about 7 pages long. They range in length based on the content and what we were able to break down, as well as the listening tour findings, and include a few more features than what I showed, and some in-depth analysis, as well as the table that I referenced, where you can see whether or not these indicators were statistically significant yourself. And then within the other piece that we wanted to share today is an update on Cottage Data2Go. We created Cottage Data2Go about 4 years ago when we collected the community health needs assessment data from 2016. And we created it as an opportunity to take data, secondary data, and break it down at the sub-county level. We saw that that was a need among community organizations. So we took things like US Census data, EPA data, FBI crime data, and we mapped that across Santa Barbara County at the census tract and census designated place level. And in doing this, we also knew that we wanted to add in our 2016 and now 2019 community health needs assessment data. So when you enter into the site and you go in, I'll come back to this maps tab in just a second, but first to show you this health section, this is a section that we had added after our 2016 community health needs assessment, and it's the data for all of the community health needs assessment, or for many of the community health needs assessment indicators, and we have those under select the question, and you can find those indicators listed here and see them broken down at the county level, and then broken down by subpopulations. And you can choose to add or choose to subtract or add on those subpopulations and kind of customize the data view that you want to look at. So all of these data are now publicly available and on our website, updated for the 2019 Community Health Needs Assessment. And this year, we've also been able to update the Maps tab, which this was truly a desire of ours in 2016, and we worked really hard to try and bring this this new feature to from the 2016 data to the website, but it didn't work out, and now we have been working with the University of Pittsburgh partners to be able to take these data that we collected from the 2019 Community Health Needs Assessment to the sub-county level. This, again, was a request that we heard from community organizations who said they really wanted to learn, they really wanted to see the community health needs assessment data broken down by communities, and we were able to do that on this tool at the census tract level. So when you come in here and you select an indicator, and then you go to these ones in orange are the ones that are from the Santa Barbara, the 2019 Community Health Needs Assessment. And if I come over and select food insecurity, it displays food insecurity at the county for the whole entire county. Areas that are white, we had to suppress the data. There weren't enough findings for that particular question, and so those data are suppressed. I'm going to zoom in here so we can see a little bit better within Santa Barbara specifically. And when we zoom in, we can see kind of the heart of downtown Santa Barbara here. And what we've done with this, and you'll notice, is a little bit different than how we map some of these indicators from like the US Census data and the crime data. We're able to list for a census tract for the US Census data a specific rate within that census tract. We weren't able to do that with these data, and so what we are able to show are ranges. And this provides users with an ability to compare census tracts with each other and understand how certain census tracts are more impacted or less impacted than others throughout the county. And so, for example, you can see here on the west side of Santa Barbara, that they fall into the highest tier for those individuals who are identified as food insecure. And then you can compare that to their nearby census tract who are experiencing food insecurity at much lower rates. What we used here from the method standpoint is there's a project called the 500 Cities Project that comes from the CDC, and they mapped within the 500 largest cities in the United States. They broke down amongst those census tracts some of the US Census data, and you're able to kind of go in and look at that. And that actually exists for Santa Barbara, the city of Santa Barbara, but it does not exist for the entire county. So we use that same methodology to be able to bring that to the entire county using the 2019 Community Health Needs Assessment data. When we get down to data that's being presented that are really, randomized sample data that's being weighted to match the county and taken to that sub-county level, that's where we needed to present the data from a reliability standpoint as an estimate, not more as a comparison rather than an exact number. So that's Cottage Data2Go, and that feature is live and available, and we hope that you'll take advantage of that. I'm going to switch back over here really quickly and talk about a couple of next steps and then leave a few minutes here for questions and answers. So next steps from this, as we've mentioned before, that we'll be conducting these community conversations, adding to the health indicator profiles that are available on the website, and sharing that additional analysis. And then we are available, as I showed you, the community health needs assessment information that's available on the website and Cottage Data2Go. Katie mentioned earlier, we really want you to share this out in the community. We want this to be as widely used and available to people as possible. And so we're happy to help spread that word. And if you have an organization that would be helpful for us to present to, we would be happy to do that. And then we're also open to taking data inquiries and requests. And becoming soon, as Katie mentioned, we're hiring an epidemiologist and in the process of doing that. And so with that, we'll have expanded capacity to field some of these questions and provide responses. So I would love at this point to open it up to any other additional questions that people have. And Todd and Nora are also available on the line, and I think Rebecca from Measure of America to answer any of those questions. I know we fielded many of them as we went. And you're also welcome to reach out to us afterwards. If you don't have my contact information, please feel free to reach out via Leah, who you RSVP'd to, and she can help connect you in. All right. I'm not seeing any additional questions at this time. Again, thank you so much to everybody for attending and participating in this. These resources are publicly available on our website and on cottagedata2go.org. Feel free to reach out to us anytime with questions, presentation requests, or data inquiries. And with that, great. With that, we'll wish everybody have a great day, and thank you so much for attending.